Hello, thank you for joining us for a discussion on honoring patients' choices for end-of-life care. I'm Dr. Elie. I'm an associate professor in the Department of Emergency Medicine, the Division of Critical Care, and in the Division of Palliative Medicine as part of the Department of Medicine. I'm also the Chief Medical Officer at Haven Hospice. And today we're just going to talk about advanced planning and choices that often patients and families should be talking about around end-of-life care. So as an introduction, I just wanted to present a concept that the United States is slowly growing older, right? So there's a growing aging population in the United States of America, which is helping us to shift our focus into looking at the way that people live, but also looking at the way that people age in our country, particularly in the state of Florida. And some facts that we should discuss to start off is that when looking at the Medicare population, and so that's the population over the age of 65 in the United States, the vast majority of Medicare beneficiaries, that's 86%, prefer to spend as much time as possible in their home in their last months of life. 3/4 of patients would not choose a treatment if it were to result in a decrease in cognitive function, meaning that they'd really want to be able to maintain their independence for as long as possible. And more than half of patients over the age of 65 will have a visit to an emergency department. And that'll happen within the last month of their life, where they often are admitted to the intensive care unit and will experience a death. So when should you be thinking about end-of-life care? Well, we should be thinking about it when we have advanced illness, and I'll provide some examples of that. So dementia and Alzheimer's disease, especially as it becomes advanced, should be considered a condition that could be important as aged people move towards the end of life. We do know that this is one of the most common causes of death in the United States. It's the 7th leading cause of death. And about 60 to 80% of dementia is actually accounted for by Alzheimer's disease. Heart and lung disease, especially when it's advanced, should also be considered as part of a discussion you have with your physicians regarding end-of-life care, especially when conditions such as advanced heart failure or advanced COPD may be present. In patients with cancer, if the cancer is considered at an advanced stage, metastatic or non-curable, again, a discussion that you should be having with your physicians about end-of-life care. Liver and kidney failure, having conditions such as advanced cirrhosis or end-stage kidney failure would be conditions that you'd want to talk to your doctor about as well. How do you know that your condition is advanced? I didn't provide a comprehensive list, but there's a number of conditions that could be advanced and could be causing you to move towards the end of life. Some characteristics that are associated with conditions that are moving towards the end of life could be increased sleeping, weight loss, the inability to communicate, increased infections, hallucinations and paranoia that didn't exist in the past, difficulty swallowing, loss of bladder and bowel control, and frequent hospitalizations are often some features that we see in patient populations that are moving towards the end of life or in the last years of their life. What's important to note is that about 1/3 of Americans in the last 6 months of their lives will see more than 10 physicians. And these 10 physicians are not necessarily speaking to each other. And in fact, we find that the physicians are operating in silos, taking care of the same patient. A lot of this leads to patients ending up in emergency departments without the counsel of any of these physicians. And a lot of these patients will also then be referred to an intensive care unit where they'll spend their last days and weeks of their life and die there. Even though, as I mentioned in the very beginning, the vast majority of patients in this category would prefer to be home, surrounded by the comforts of their environment and their family. So this is what people picture when they're at the end of life and dying. And what we're seeing in the 21st century is very aggressive care. We're seeing admissions to the intensive care unit, intubations, reliance on mechanical equipment for breathing, and for sustaining life. Prognosis is not always straightforward, and so it's the reason why everyone should be thinking about their personal plan when thinking about end-of-life care. While end-of-life care is very specific to folks that perhaps have advanced disease, it's never too early to start thinking about one's personal plan as one moves towards the end of life. So what's palliative care? Palliative care is a discipline of medicine that's designed to address people with a serious or advanced illness, but it can be provided to anybody at any age. So anybody that, regardless of age and regardless of the stage of the serious illness, palliative care referral could be appropriate. Palliative care involves specially trained teams of physicians, nurse practitioners, physician's assistants, nurses, and other specialists that really help to provide comprehensive approaches to managing the patient's illness and their symptoms. Hospice is introduced when palliative care becomes optimized and there is a concern by the provider that the patient is moving towards the end of life. Hospice can be provided in a variety of settings. While we may see hospice in hospitals, more than likely, most patients that are on hospice will be able to receive all of their care in their own home. So while all care is palliative, not all palliative care is hospice. So again, palliative care and hospice can be provided to patients of any age. We tend to think about the geriatric population, but we understand that patients at any age can be appropriate for palliative care. Palliative care and hospice are really designed to help to relieve patients from their symptoms. So when we think of the common flu or the common cold, for instance, we often think of palliative care. Although we don't call it that. And that's because when managing the common cold or the flu, we're managing the discomforting symptoms of fever with fever-reducing medications. We're giving patients decongestants and fluids. These are all TLC, but they're all palliative because it's not necessarily a cure for the common cold or the flu, but these are treatments that are designed to optimize comfort as your body deals with the underlying infection. But palliative care is also about managing the distress that comes from those symptoms. There's a lot of psychological and emotional distress that can be evoked from having a serious illness. There's also spiritual distress. And you could imagine that the prospect of losing one's independence or even dying from their disease is very difficult. And so palliative care, in addition to managing physical symptoms, also manages emotional, psychological, and spiritual distress. Palliative care is also about improving quality of life. So rather than thinking about the prognosis or the quantity of time left for the patient, it also involves some medical trade-offs in order to achieve a medical goal. So for instance, painting, being involved in the arts, and going out to see a show or a sports game may be very important in enhancing someone's quality of life. And when thinking about end of life, oftentimes people have goals. And so when we think about the sorts of things that we can do to help people achieve those goals, we also think about palliative care, helping people to really focus on that quality rather than the quantity, so that you can take that fishing trip or go hiking with your family members. By doing this, oftentimes there are what we call medical trade-offs. And those medical trade-offs are negotiated with your physician in order for you to meet your goals. For instance, one person may be at the end of life, but may find that that goal is awaiting the birth of a child. And palliative care, hospice, and other goals that you have can help you to meet that goal of meeting your grandchild or attending a wedding. And sometimes those trade-offs have to do with spending time with family and friends. So as a good example of how palliative care can help patients, a patient may decide to decline certain types of therapy that would prevent them from enjoying a meal with friends because it would cause nausea, vomiting, and loss of appetite. Palliative care also helps with caregiver quality of life. We understand that as people become more ill and they start losing their independence, there may be an increased reliance on family and friends for support. And that can actually be very burdensome over time. And palliative care can really help help the caregivers to have the resources needed in order to provide the best care for their loved ones. Another important feature of palliative care is thinking about advanced directives. So palliative care clinicians can provide guidance in making key decisions regarding health in the event a patient loses their capacity. This is frequently a key service shown to improve the likelihood that a person's wishes are honored. So let's talk about some advanced directives. We're going to talk about healthcare surrogate, living will, 5 wishes, do not resuscitate, and the e-most and post. So a healthcare surrogate is a form that you complete that defines or indicates which person will advocate for you. That person will essentially advocate for your healthcare decisions when you lack the capacity to communicate your wishes directly to your physician. So this person should really be someone that understands your choices or preferences for medical care, and you have to choose who that person is, and you have to make sure that that person understands what it is that you would want in the event that you could not speak for yourself. Oftentimes, people tend to choose a close family member, but sometimes you may choose a close friend, especially if you feel your family member may not necessarily go along with your preferences. A living will is not a will, not the formal will that we would think about where you're leaving your belongings behind, but rather is a will that communicates to your physician. The topics that are outlined in a living will really help the physician understand what your preferences are around resuscitation, your quality of life, and end-of-life treatments, which may include tube feedings or hydration or antibiotics, and whether or not you'd prefer to receive those if you were incapacitated or if you were, in fact, moving towards a point of death. Another type of living will is also called 5 wishes. 5 wishes is very similar to the items that I mentioned above, except it also allows for you to freely include aspects of your personal, emotional, and spiritual needs that you'd want to be addressed by your medical team that are in addition to your medical wishes. A do not resuscitate order, or DNR, is a medical order that is signed by a physician and by the patient or the patient's representative. This form instructs any healthcare provider that they should not perform cardiopulmonary resuscitation if, for some reason, you were to stop breathing or if your heart were to stop beating. This form must be signed by a physician, and it must be yellow in order to be legally standing in the state of Florida. Other states outside of Florida will use what's called an e-most or a POST, which stands for Medical Orders of Life-Sustaining Treatment or Physician Order of Life-Sustaining Treatment. While this yellow form is only found in Florida, it can be utilized in any state. And similar to that, if you have filled out an e-most or POST in another state, it can be brought to the state of Florida and will be honored in the state of Florida. So in conclusion, when thinking about choices at the end of life, options such as completing your advanced directives, engaging in palliative care, or if you're at the end of life, engaging in hospice has been shown to improve a lot of things. It improves the utilization of ICU beds in hospitals. It improves the sense of loneliness. It improves the symptoms that are associated with serious illness. It improves the strain that is experienced by caregivers. It improves quality of life for the patient and for caregivers. It also improves the sense of bereavement or the grief that might be experienced by caregivers after someone has died. When approaching the end of life, planning early helps patients and families. Introducing additional resources such as palliative care can be an additional layer of care and support that provides a real comprehensive approach to patients and for patients and their caregivers. What this also does is it helps to bridge the gap of communication, and that's really important because there's often gaps of communication between the patients, their caregivers, and their providers. There may be multiple medical specialties, and it may be a very confusing time. So palliative care helps to align all of those resources, but also helps to achieve the goals that are defined by the patient and their loved ones. I have 2 websites here for everyone's reference at UF Health and also at the National Institute of Aging for those of you who might be interested in learning more about how to complete advanced directives. Thank you very much.